Good afternoon, esteemed members of Vaccine Choice Canada. My name is Dr. Jessica Rose, and today I'm going to present some findings from a study that I've recently submitted for peer review and had accepted, entitled A Report on the U.S. Vaccine Adverse Events Reporting System of the COVID-19 mRNA Biologicals. I am a Canadian researcher who is currently somewhat landlocked in Israel due to the stringent measures that are ongoing for over a year now. And my title slide is actually a real billboard, of which there are many, that are showing across the country as part of the rollout of these products into as many people as possible. And we are currently in the beginning of the second massive rollout, and the target population are children and pregnant women. So this is not a joke. It's not an advertisement for a new theatrical event. That's what it looks like, but that's not what it is. So this is the current feeling in Israel right now. I will refer to the products as biologicals or injections or products from here on in. So first of all, some background. What is VAERS? VAERS is an acronym for the Vaccine Adverse Event Reporting System, and it was created by the Food and Drug Administration and the Centers for Disease Control and Prevention to receive reports about adverse events that may be associated with vaccines. And its primary purpose is to serve as an early warning or signaling system for adverse events that aren't detected during pre-market testing. An adverse event itself is defined as any untoward or unfavorable medical occurrence in a human study participant that could include any abnormal physical exam or laboratory finding, symptom, or disease. Could be temporally associated with the participant's involvement in the research, whether or not considered related to the participation in the research. Most vaccine adverse event reports concern relatively minor events, such as injection site pain or headache or chills or general malaise. However, the reports of serious or severe adverse events do exist, and they're of course the greatest concern and receive the most careful scrutiny, or rather they should, by VAERS staff and healthcare professionals. A severe adverse event is defined as any adverse event that results in death or that is life-threatening or places the participant in the experiment at immediate risk of death from the event as it occurred. It may require prolonged hospitalization or cause persistent or significant disability or incapacity, may result in congenital anomalies or birth defects, or some other condition which investigators judge to represent significant hazards. For the purposes of my study, I considered deaths, hospitalizations, and emergency doctor visits as severe adverse events. So the system is absolutely essential. It's to warn of adverse events that aren't detected during pre-market testing, as I mentioned. This is primarily due to the exclusion criteria requirements. But it's very important to realize that under-reporting and also under-recording is a serious problem in this system. It's a great system, but it's imperfect. There have been studies done that show somewhere between 1 and 10% of actual reports are represented by the reports that make it into the VAERS database. So I will say it here and I will stress it throughout the presentation. Whatever I'm going to show you here data-wise, it's most likely a massive underestimation of the actual numbers. I would go as far to say as 2 orders of magnitude smaller, but that's that's conjecture at this point. But safe to say, these are definitely lower numbers than the actual numbers. So to date, the global rollout of the Pfizer, Moderna, and Janssen products have led to tens of thousands of individuals reporting adverse events using the VAERS system alone, and these do include severe adverse events. So today I'm going to cover three main findings from my analysis. The first regards the absolute numbers with respect to VAERS IDs. Each ID represents a single individual who successfully made a report. Also severe adverse events, which according to the VAERS handbook, typically represent 15% of the data, and more specifically, immunological adverse events. The data set in this particular category is growing very fast. And many, if not all, immunological adverse events could be considered severe due to the purpose of the immune system. The second point will be on the subject of causation. It is likely that the injections are actually causing the adverse events, especially in certain cases that I will show here today. And the third point is on the subject of breakthrough infections, COVID-19 breakthrough infections. And I'll cover what that is in the following slides. So let's look at the first finding. So I want to ask everybody in the audience a question, which is probably on your mind anyway. What does the VAERS data look like now? Is it comparable to the VAERS data accumulated from last year or the year before? This is a very important question to ask, because if the data looks the same, then there's probably nothing to be alarmed about at this point. So let's look at the absolute numbers. This is a time series plot showing the VAERS data by absolute VAERS ID number by year, and the VAERS systems came into effect in 1990. So this is the accumulated data from the very beginning of the VAERS data being used in the public. So what you can see here is a general trend upward. And I actually have normalized this to the US population in terms of growth. And this isn't due to population growth. This is something happening representative of the two things. One, the growth in the absolute number of vaccines getting into the population, and also the increase in the number of adverse events due to this increase in the number of injections. So if we extrapolate along this trend line, which is on about a 45-degree angle upward, we can make a guesstimate of where the absolute number of VAERS IDs should be by the end of 2021. And it's, I mean, I'm not saying that this is exact. It's just an idea that I had. Okay, so if this trend line continues in this direction on this angle, what are we looking at number-wise for IDs for the end of 2021? And what we're looking at is something about 62,000 adverse event reports. So the bottom line is the injury reports are on the rise, and we would expect to see something between 60,000 and 70,000 adverse events by the end of 2021 if we were on the same trajectory. So on the right is another time series plot that represents the COVID-19 associated incidents only. This is not the total sum of all the adverse event reports for all the vaccines given for 2021. This is only the COVID-19 related ones by week. And so as you can see, up until the end of February, there's nothing much to see. It's not a flat line, but it's definitely not trending upward. There's no exponential growth in sight. However, sometime in the early part of March, these numbers start to go up. And again, sometime near the beginning of April, they really start to shoot up. I'm not going to speculate as to why this is. Needless to say, in the last, the VAERS data is updated every Friday. And the last update that was entered into the database, which is also backlogged, there was a 33% increase in the number of IDs, which is by far the highest jump that I've seen week to week. So the trend, I mean, it certainly looks like it's starting to grow exponentially. We can't know. This is clearly going to be a logistic curve in the end, and we can't know what part of the curve we're on right now, but it certainly appears early April that this is trending upward in an exponential way, which is quite scary. And what's even more scary are the absolute numbers. We've already far surpassed, we're almost double now, absolute count-wise, in the adverse event reports. Now, in the end of April, early May, than for the entire year last year. That alone is quite striking. So the COVID-19 injection injury reports are definitely on the rise. And, this is the same plot, except on the left, it shows you the VAERS, the data as per million. So it's a nicer way to show the data, and it confirms that that when I normalized to the U.S. population, it showed that it wasn't due to the rise in population alone. So what about the severe adverse events? Because, I mean, yes, the number of adverse events are going up. We can see that, it's very clear. But if these adverse events only represent, say, injection site swelling and headaches, I mean, it's still concerning, but it's not as concerning. So it's very important to find out what proportion of these and what types of these are severe adverse events. So as I mentioned before, the VAERS handbook states that approximately 15% of reported AEs are typically severe adverse events. So we are at 20% now, and this percentage actually peaked at 57 in mid-January. So there is an ebb and flow of percentage here, but it's still, as of today, higher than the expected, than the standard 15%. This is concerning as well. So to answer the question, does the VAERS data, in terms of the VAERS ID counts and the severe adverse event frequencies look the same as it did last year? No, it certainly does not. So what else is standing out? I want to show by categorization what's happening in terms of the adverse event data. So what I did was I separated by deaths, hospitalizations, emergency room visits, cardiovascular events, neurological events, and immunological events, which is very important to me because I'm an immunologist. So what I did was I plotted, on the left is a time series plot showing the change in each of these categories by absolute number as the weeks progress. So as you can see, there wasn't much to see until March, and then all of a sudden things started to change. Now it's far less dramatic in the death category, but there is still an upward trend. And what's notable here is the rapid rise in the immunological adverse events. Now, these adverse events include immunological mediators and also immunological effects. So this could be changes, for example, in T cell counts, cytokine counts, or the presentation of MS again, for example. So this encompasses both of those immunological factors. So they're definitely on the rise. And I also wanted to look at the events per million fully vaccinated, because this is far more meaningful data. So as per group, as per category, again, what we see is that there isn't much changing in the first 2 months or so, but then in the beginning of March, we see this jump in immunological adverse events in terms of the fully vaccinated population. Now, besides the fact that it's pretty clear now that the immunological adverse events are on the rise, it's very concerning to think about what's going on here and why it's manifesting, what's behind this. James Lyons Weiler wrote a paper called Pathogenic Priming Likely Contributes to Serious and Critical Illness and Mortality in COVID-19 via Autoimmunity recently. And this paper might actually have the answers. It might actually explain the rapid rise in the immunological adverse events. I won't get into the paper in detail, but safe to say that pathogenic priming happens due to homology between human and viral proteins, and it can lead to autoimmunity, both via a virus, for example, or via a vaccine. Homology is just a similarity due to shared ancestry between a pair of structures of genes in different taxa. So what he found was that 1/3 of the immunogenic proteins in SARS-CoV-2 have potentially problematic homology to proteins that are key, not just to humans, but to the human adaptive immune system. And the implications of this are absolutely staggering. So I'm not saying that that's what's happening here, but it very well could be. And this is very concerning. Anybody involved in administering these products needs this information so that they can inform their patients. To summarize the first point, VAERS ID counts are already higher than last year. They're almost twice as high. Since this trend looks exponential, or at least we're in the exponential part of the growth curve, of the logistic curve, it looks like it's going to keep trending. So we'll have to keep a very close eye on the numbers in the coming weeks. The severe adverse event reports are higher than average, which is not typical. And the immunological adverse events are standing out. And this could be due to pathogenic priming. And that warrants many, many studies to be done, both on the bench and clinically. Let's move on to the second finding. This involves causation, an investigation into whether or not the injections are actually causing the adverse events, because this is a huge debate. And in biology and epidemiology, it's an incredibly hard thing to show because of many factors. So in order to help data scientists and epidemiologists provide evidence, strong evidence to support causality, there's something called the Bradford-Hill criteria. It's a series of 9 criteria to provide epidemiological evidence of a causal relationship between a presumed cause and an observed effect. It was developed by an English statistician named Austin Bradford Hill in the 60s. And I'm not going to go through the 9 points, but safe to say, you need certain ones. Certain ones you cannot claim any kind of causality without. So those ones would be association or correlation, for example, specificity, time ordering. This is perhaps the most important one because, I mean, if you're thinking of causation, changing one thing changes another. I mean, there's a temporal aspect here. You change one thing and then another thing changes. So time ordering is very important. And non-spuriousness, of course. This is very difficult to prove. This means that you can show that it is in fact one thing causing an effect without having the effect actually being caused by a different thing that you hadn't factored in, for example. So I do actually show this, not here in this presentation. That work isn't shown, but it's shown in the published work. So I did look at this, but I won't show it today. So I want everyone to do a little thought experiment. I would assume that everybody here in this audience doesn't have a problem imagining that there is a connection, a causation effect between injections and certain pathologies or diseases, I suppose I'll call them, or adverse events. But for the sake of the presentation, I'd like everyone to suspend what you currently believe and just assume that the injections have absolutely nothing to do with the adverse events. Okay, is everybody there? Is everybody in that headspace? If you were going to plot what the trajectory would look like in terms of the time difference between the vaccination date and the onset of symptoms date against the percent of adverse events themselves, what would the trajectory look like? Everyone should have kind of an idea in their head of what it might look like. So within the VAERS data set, we have column vector data for the vaccination date. So everybody who calls in an adverse event has their vaccination date recorded, the onset of their symptom date recorded, of course. And so what I've done is I've calculated the amount of time in days between these two variables, and I've plotted them on the x-axis here. So 0 represents, I so-called no time has passed. So in actuality, it's anywhere between, say, a few seconds to 23 hours and 59 seconds, and so on, along the x-axis. So what we would expect in terms of the percent of the reported AEs is for them to be the same for any given time period before or after injection if the injections have nothing to do with the AEs. We would see a trajectory along the x-axis that has an even distribution around or about, the y-axis. Correct? But this is not what we see. And I checked this in each of the categories that I mentioned in the earlier slides, each and all, and plus a couple more. And what we're seeing is something more like this. So this is the actual observed values plotted on this on the x-axis, which represent the time differences between the vaccine date and the onset of adverse event date, against the percent of recorded deaths. So this is death data here. And not only is it visually striking how different the observed values are between the expected values, but this is statistically significant. You can test this using a chi-square test, and I did. The significance is very high. There shouldn't be an excess of reports on days 0 and 1 in particular if there's no causation. And not only did I find this in the death category, but I found it in the ER and the hospitalizations. And I found it in the cardiovascular, neurological, and immunological adverse events as well. So it's clear that the trend is the same in these groups. So the evidence is mounting. Here we have correlation, we have time ordering, we have specificity, along with a number of the other the points that I mentioned before. This is just a side point here. Many of you probably noticed that there's this bump in the immunological trajectory. So what may be going on here approximately 7 days following injection? So I think most likely that this is just normal immune function responding to new antigenic proteins. So if you inject a foreign protein, if you inject a foreign mRNA in the form of a template inside a lipid nanoparticle with the purpose of using host cell machinery to use the mRNA template to generate foreign proteins, and the body naturally is going to mount an immune response to these foreign proteins, that would probably happen within 7 days. I mean, it's not very scientific to say probably, but I think that that's what's going on here. So I'm not paying much mind to it. I might do so in the future. So an interesting group of adverse events that I checked in the same way are anaphylactic reactions. And I think this is important because it serves as somewhat of a positive control. Anaphylactic reactions are generally acute, brought on by a specific trigger. So you would assume a causation effect here because you have a trigger, you have a response. And so we would expect that if there is this causation effect going on, that the anaphylactic reactions, that most of the reactions would occur within even seconds, most likely minutes, but definitely within the 0 time difference frame. We would expect most, if not all. And that's what we see. We see approximately 90% of all of these reactions occurring within the first day. So this is somewhat of a positive control, as I mentioned, and more supporting evidence as to the system of checking. And very importantly, as another standalone adverse event, I examined the spontaneous abortions because this is a very, very concerning thing. Female reproductive health is very, very important. And if there is even a possibility that these injections are causing damage in this way, then we absolutely need to know, and we need to do something about it right away. In addition to the spontaneous abortions, but related, many women have been reporting breakthrough bleeding and dysmenorrhea. There's all sorts of things going on here, and although they are anecdotal for now, the peer-reviewed studies need to be done, and they need to be done now. These are particularly concerning, these types of events. Spontaneous abortions aren't actually reported as deaths in the adverse event reporting system, but they are clearly. And apart from that, it's a very, very distressing thing to have to go through for a woman, and women comprise half the population. So this is a very important issue. So just to summarize the causation findings, I was able to prove association and specificity, of course, by categorizing by specific adverse event. I also showed this using heat maps, which I also don't show here. Time ordering, of course, this is the most important point, and clearly one comes before the other. In many times, very, very closely after. And non-spuriousness, it's not shown. So for example, somebody might say, well, how do you know this wasn't caused by a pre-existing condition? How do you know this wasn't caused by a medication that they were on? Well, I checked, and there was no statistically significant contribution from either of those 2 points that I did check. So the evidence is there. So ultimately, to answer the question, are the injections causing the AEs, forgive me, my answer would be it's very likely based on this evidence. And may I also point out at this point that the evidence pile is growing. So if I was going to take a guess, I would say that this evidence is going to become much stronger very quickly in the coming weeks. So last but not least, in the findings, I would like to discuss breakthrough infections. A breakthrough infection is when you actually get the illness, let's call it, that you were vaccinating against. So to date, we have 1,930 COVID-19 breakthrough cases. That represents approximately 1.8% of the total adverse events. And what's more interesting is that when I looked at the contribution from each vaccine manufacturer or biological manufacturer, it's quite striking and statistically significant that Pfizer is a much larger contributor. So I wanted to know if this was actually due to the product itself, or perhaps maybe it was due to the distribution of the administration of the products in the total U.S. population. Because keep in mind that this is a sample, and we have to keep in mind the population base as well. So Pfizer does comprise a large percent of the reports, and it is statistically significant, but we need to know the distribution of the products in the entire population before we can make any suggestions as to whether or not Pfizer is contributing more or associated more with COVID-19 breakthrough cases. So I looked at the distribution of these 3 products, the Pfizer, the Moderna, and the Janssen in the US population. And the Moderna and the Pfizer they're pretty much half and half. There's nothing statistically significant here. So even though Pfizer comprises, or since Pfizer comprises approximately half of the fully vaccinated population, we can actually make a suggestion that Pfizer is more highly associated with breakthrough infections. Also, here, this isn't related, but I'd like to point out that the Janssen products haven't been in the population for more than, I would say, a maximum of 4 weeks at this point. This is early May. And they already represent 1/5 of the adverse events. It doesn't take a scientist to suggest that perhaps these products, in particular the Janssen product, they require further study before they keep being put into the population. Now, what about deaths? Because we all know that this entire thing is based on a fear of dying from COVID-19. So, what percentage of the COVID-19 breakthrough cases from the injections are causing death? So, just to contextualize for everyone, we're talking about people that we are assuming are healthy in terms of COVID-19. They do not have it, which is an assumption. It's possible that they do at the time of the injection, but I'm also going to assume that there's testing, so-called, surrounding the injection time frame so that you can assess clinically the state of these people who are getting these injections at the time and before the injection. So let's assume they're COVID-19 negative, so-called. They get the injection, they get COVID-19, and then they die. I'd like to just stress the irony of that, first of all, and to point out that 8% of all the COVID-19 breakthrough cases died, and this is not a small number to me. And considering we are seeing a trend upward, this number is going to continue to grow. It's not tapering off. Interestingly, a higher percentage of deaths were associated with the Moderna product. And this is quite interesting and also somewhat lucky in a way, because if we think back to the previous slides, that Pfizer seems to be more highly associated with COVID-19 breakthrough infections, then it's kind of a good thing that it's also not more highly associated with death. I mean, none of this is good, but it's a better scenario. So are these deaths related to age? Most of you are probably wondering about age relation in this data so far, and very much so. Most of the people who had a breakthrough COVID-19 infection who died were quite old. So this isn't surprising. It's not shocking. We would expect this because, I mean, people die. It happens. But no individuals less than 40 years old died from a breakthrough COVID-19 infection. Again, this isn't totally surprising. It's just, it's kind of a confirmation of what we already know. So the deaths are certainly related to age, which again is not surprising. So to summarize the breakthrough infection findings, COVID-19 and COVID-19 death, adverse events following injection occur. So we're seeing breakthrough events and we're seeing them rising. The number is rising from week to week. It's more frequent with the Pfizer product, breakthrough infections, and Moderna is it's slightly more associated with death from COVID-19 breakthrough infections. And the deaths are related to age. So to summarize the three findings that I've discussed today from the study that I did, in my view, 3 points of convention or 3 accepted views have been challenged. The first one are these severe adverse events. Now, it's very clear, this is not biased, that the severe adverse events are more frequent. They've peaked at 57%. I mean, this is very concerning. And they're already, or they remain well above the 15% percentage of the adverse event total, which is still high. Number two, the causation evidence contradicts the notion that the injections are not causing the adverse events. Even if you still believe that there's no connection between the injections and the adverse events, you would have to explain very clearly why we're seeing what we're seeing in terms of these points that show or provide evidence for causation. I really, really, really invite anybody to show me, using statistical techniques or whatnot, why we're seeing what we're seeing if it's not due to causation. I invite it. And number three, breakthrough infections, while infrequent, they do call into question the efficacy of these biologicals, because from a layman's point of view, the reason why most people are running out to get these injections, you would think, is to provide protection for themselves, because the idea is that once you get, let's say, vaccinated against a pathogen, that you won't get sick from that pathogen, and you definitely won't die from it. That would be the expectation in my eyes. So if people knew that this was a problem, they might think twice. And therefore, I think it's absolutely essential that people know. So any risk-benefit analysis has to include a discussion of therapeutics on this subject. We have repurposed drugs like chloroquine and zinc combination, we have ivermectin, we have many different repurposed drugs that have been proven safe and effective and actually FDA approved for decades. And they show positive results in patients from with early symptoms. Some of them even show positive results in patients who have made it to the ICU. It's very, very strange to me, and it's unclear why these drugs aren't being more extensively promoted as effective tools in this fight. So why the fast tracking of new and expensive technologies if we have these therapeutics in our hands, ready to use? Why? It's a huge, huge drain on economic resources, time, and energy that, in my opinion, is completely unnecessary. I mean, if you even look at it from the point of view of the mortality rate of this virus itself, none of these expenditures in time, money, and effort needed to be made. Even apart from therapeutics, apart from repurposed drugs, there are easy and cost-effective ways to prevent getting sick, not just from COVID-19, but from many viruses. And that's to regularly get your vitamin D levels checked and make sure that you're not deficient. Because the immune system cannot function properly if you are vitamin D deficient. It's not granola, it's fact. That's how the immune system functions. Biochemically, it needs vitamin D as a source. And you need to get vitamin D as a source from the sun or by supplementing if you live in a place where there isn't a lot of sun. This is very important to immune system health. Of course, regular exercise, clean food, and clean water is essential as well. Try to limit your exposure to pollution. All of these things are absolutely essential to an optimally functioning immune system. And the more optimally functioning your immune system is, the less serious pathologies you will suffer from any viral infection, including this one. So, final thoughts. There's currently no way to predict the potential detrimental outcomes with regards to severe adverse event occurrences in the long term, not even in the short term. And what concerns me the most are these immunological complications that are on our doorstep. We're hearing more and more about thrombotic events, bleeding events, female reproductive events, and we don't know why. These things need to be studied right now. So, to end on a little a light note, because I think we could all use a little levity. This little cartoon has made many people I know laugh in these terrible times. So I think that's also very important for the strength of our immune systems to make sure. I'm not saying you shouldn't cry, but you should definitely try and laugh a little every day. And that's the end of my my presentation. I welcome questions. I'd like to thank James Lyons-Weiler for giving me the opportunity to present this work to Vaccine Choice Canada today, and I look forward to any future collaboration. This is basically how I'm spending my time now. I mean, I am a data scientist, so it's also it's fun for me. So thank you very much, and I bid you all farewell and a great day.